So thank you for the introduction. Thank you for having me here. I realize some of this will be done via an interpreter, so I'll try to not speak too fast. But I appreciate the opportunity here to talk about something I'm very passionate about, which is really cancer care in the older adult. And really the question here is, how old is too old, and how can we really adjust our treatments in older patients? So I'm a geriatrician and a medical oncologist. Clinically, I'm a GI medical oncologist, mostly focused in colorectal and pancreatic cancer. But a lot of these principles are true regardless of cancer type. So I did just want to mention my disclosures. Not a lot here, mostly with CareVive, Cardinal Health, and some research grants. In terms of a roadmap, first I wanted to provide an overview of the whole field of geriatric oncology, why this is important demographics, and then review some strategies to aid in the assessment of older adults, really to get at that idea of who may benefit and who's at risk for adverse events undergoing cancer treatments. And lastly, in particular, look at the role of and barriers to using the geriatric assessment to aid in the management of these older patients. So first off, cancer disease of older adults. The majority of cancer diagnosis and the vast majority of cancer deaths occur in older patients over the age of 65. As you can see here, which is the latest data from the SEER registry, it's really not until the 5th or 6th decade of life that we start seeing increases in the cancer incidence rates, which really peaks in the 8th decade of life. In the United States currently, the median age of a cancer diagnosis is 67, and I imagine that's not greatly different there in Panama City and in Central America. And really, this is notable now, but given changing demographics, that it's expected that 70% of all new cancer diagnosis will be in those over the age of 65. And it's not always just those over the age of 65 that are challenging. The number of adults over the age of 80 and even 90 will be increasing fourfold in the coming decades. On top of that, a lot of our cancer survivors are living a lot longer, and the vast majority of cancer survivors are also in this older adult segment. As you can see here, today already the majority are between the ages of 65 to 74 and 75 plus, and the trends estimated out to 2040 is that this will represent the vast majority of our cancer survivors as well. So this is important for not only active treatment, but also in those in the survivorship phase as well. So you may ask yourself, why does that matter? What does that have to do with our oncology care? Well, I think it's really important to kind of think about the aging process and the implications that might have for cancer treatment. Aging is a heterogeneous process. Unlike the development process, which is fairly linear and predictable, the aging process is heterogeneous and very specific to the individual based on genetics, environmental factors, and lifestyle factors. The pace at which we age is unique to the individual. Now, you may not notice these differences in aging between those and their, say, 4th, 5th decade of life, but once you get up into the 7th and 8th decade of life, you can start noticing very significant differences between people of the same chronologic age. When we take, say, an 80-year-old, you can have some that are highly functional, have very few medical problems, don't take regular medications, and are able to do things such as water skiing on the weekends, whereas you can have other individuals of the exact same chronological age that may be severely functionally impaired, have multiple medications and comorbid conditions, and age alone is unable to really detect these differences. Now, if everyone that stepped into our clinics looked like one of these two patients, this would be a rather easy thing. These are the patients that are really on the extremes of high function and low function. But really this represents a spectrum of overall health status, and it's all these patients in between that are made much more challenging. When an older adult is diagnosed and undergoes cancer treatments, their outcomes are highly variable. Some older adults, regardless of age, have similar benefits as their younger counterparts, whereas there are others that we know at increased risk of surgical complications, side effects from radiation, as well as severe chemotherapy and hospitalizations. What we do know is your health status coming into the cancer diagnosis is probably our best predictor of who will do well and tolerate cancer treatments. So that brings up the question of how do we assess older adults with cancer? And this really remains a clinical challenge and a conundrum today. We know that age alone and performance status, which is what's commonly used in oncology to guide care, is really insufficient and is not sensitive to picking up a lot of impairments that we see with aging. And really, we need better ways to assess older adults to guide care. And frankly, this is what I do. So, I do a lot of clinical care. I do a lot of research in the cancer and aging space, and figuring out better ways to assess and help aid decision-making in older cancer patients is I think a fascinating area where there's a lot of research and ongoing efforts. So simply put, it's helpful to know what people are doing today. And actually, as part of ASCO, we did an international survey of medical oncologists, of which I think about 5% were actually from Central America. And as part of this, we asked, how do you assess, or do you assess older adults differently than younger patients? And as I think many of us expected, the vast majority of practitioners or clinical teams said they did, that they recognized there was something inherently different in older adults, and that about 90% of the time they were at least evaluating them in some way different than their younger patients. But when you asked in which ways they're doing it, it really seemed to be these more informal assessments that 70% of providers were using, and only about 29%, or roughly a third, were using a more formal, more objective measure when evaluating older adults. And I get this brings us to this concept of what we like to think of as the geriatric oncology iceberg, which is, part of our standard assessment includes this age, performance status. We obviously want biopsies, we want to know tumor mutations, immunohistochemistry, all these tumor characteristics that are critically important. We also need to know their kidney function, their hepatic function. These sorts of things are really important when coming up with cancer treatment plans. But I would argue in the older adult, this is really just the tip of the iceberg, and that there's a whole lot of issues that are just below the surface that are as important as that when making treatment decisions. And these include things like polypharmacy and comorbidities, falls and psychosocial dysfunction, social support, sarcopenia and nutritional deficits, cognitive impairment, and functional deficits. And we really have to take in this whole picture when we're thinking and planning and making our treatment plans. So how does one assess all of those things? And that's really where this concept of the geriatric assessment becomes important and a big part of what we do. So what is a geriatric assessment? It is a multidimensional interdisciplinary approach to the evaluation of an older adult, leading to the identification and treatment of areas of vulnerability. So I know that sounds like a lot. Really, this is what I like to think of as a very, very comprehensive assessment that covers all these important domains that we know about in aging, which includes your usual stuff. We often do a comorbidity evaluation and intake medications, but it also does a more detailed and systematic assessment of function, cognition, nutrition, and all of these other areas. Now, it's importantly involves, and I'll talk about this a few times, an evaluation and a management piece. So not only are you supposed to assess these things, most of these things that you're assessing can lend itself to an intervention. For example, if someone is malnourished, they should ideally get a nutrition intervention or meet a nutritionist, and you should be giving them information about how to manage their nutrition. Now, I think there's some inherent challenges to this. Everyone's busy, everyone's seeing lots of patients, gets judged on how much RVU targets we hit and billing and those sorts of things. And we don't frankly have enough time to do these comprehensive assessments. One proposed way of doing this is to partner with geriatrics. That's a model of care where, these are co-managed by a geriatrician and an oncologist both. They're clearly well-trained at doing these geriatric assessments. But one issue we've run into in the United States is shown here on this slide, where we did actually a landscape survey of 500 community oncology practices in the United States. And I don't think these results will be any different where you guys are. Perhaps they are a little different in Europe where they have different models of care. But of those clinics, we basically asked, first off, do you have duly trained geriatric oncologists at their sites? And not shockingly, no, only 2% of sites had someone that was duly trained. So clearly, not all older adults will be managed by a duly trained individual. Then we asked, do they have access to geriatrics? And about a third of sites said they had access to a geriatrician. But when we looked at that, most of these were available in the hospital, in the inpatient, or external to the practice, so someplace else locally. And only 13% of the 34% actually had a geriatrician available in the oncology clinic. So that's about 5% of community clinics in the United States have access to a geriatrician. So I would argue that, if we're really going to meaningfully do this in large numbers for the majority of our cancer patients, other than the extreme cases where these are most challenging, we're going to have to do this in absence of a geriatrician. So how can we do these geriatric assessments without actually involving geriatrics? This has been a recognized barrier to the field, and I would have to recognize one of the pioneers in this area, Arthi Huria, who unfortunately tragically passed away about 2 years ago. But in recognizing this need, she developed a majority patient-reported, or basically a survey instrument that hits all of these domains. So you can see here, there's a few things that were done by the health professional or the care team, such as the timed up and go and a cognition test. But then the vast majority of this was done by survey. So questions about activities of daily living and instrumental activities of daily living, falls, comorbid conditions, vision, hearing, mental health, social support, etc. And really this took what was typically a 2-hour geriatrics exam down to about 20 to 30 minutes, most of which was done in the waiting room just by patients. So it really made this much, much more feasible. So, we talk about using geriatric assessment, and I think a lot of people can't really visualize how this would be used. So I'd like to at least talk a little bit about ways that I think that this can be helpful when making treatment plans. Now, I would argue this is an oversimplification, but nonetheless, the kinds of things that we can discover when doing a geriatric assessment. One is we can identify some patients that are very fit. They have no functional impairments, no significant comorbid conditions, and no geriatric syndromes. And I would give these patients the green light. Now, I think they can go on with standard treatment similar to younger patients. These would be patients that frankly would be at risk for undertreatment because they do stand to benefit from standard of care treatments. Although I don't think the geriatric assessment does a whole lot more than just give us peace of mind knowing that we can proceed with our more aggressive treatments in this scenario. Now we can identify other segment which really have significant impairments, particularly in activities of daily living, which are those like bare bones activities such as transferring, getting out of bed, getting dressed. They may have significant comorbid conditions or one life-threatening comorbid condition such as limited COPD or heart failure, and then also may have clinically significant geriatric syndrome such as cognitive impairment. And really these are the patients that I would give the red light and say we need to stop. We need to be very cautious here, and that these patients are at risk for overtreatment and frankly are going to do very poorly with most of our standard oncology treatments. So unless you can really tailor this to this very frail population, most of these patients are going to not do well with standard treatments. Now the vulnerable, or this in-between category, is perhaps the largest group, particularly when we're looking at the 70s and 80-year-olds and over, and perhaps the more challenging group. But these are patients that have some impairments and activities of independent activities of daily living. That's like managing their money, driving the car, those sorts of things, going shopping, household cleaning. They may have some comorbid conditions, high blood pressure, hypothyroidism, but none that are particularly life-threatening. And they don't have any, real severe geriatric syndromes that we would see. And these are these kind of proceed with caution, that you may want to tailor their therapy a little bit, for those really, really aggressive treatments like, FOLFIRINOX. You may not want to do those. You may have to either dose reduce or modify. But I think this is a way to just kind of picture how some of the information can be helpful when completing these exams. So what is really the value of using these tools? So we've shown that it definitely uncovers problems that are not routinely found on oncology evaluations. A lot of things that are missed by your typical oncology evaluation. It can allow us to better and more accurately predict life expectancy. I find this particularly helpful in the adjuvant setting, either colorectal cancer, which we'll talk a little bit more about, or breast cancer in particular. You know, if a patient's not going to live beyond 5 or 10 years, you know, the idea of giving them adjuvant chemotherapy for their stage 1 or 2 breast cancer, you know, there's no real benefit there, right? They're going to likely die of something else before their breast cancer. It can clearly improve communication. There's been a recent publication in JAMA Oncology showing that using these assessments and as part of the care team actually improves communication and better conversations around the risk and benefits of these treatments. And then lastly, and probably most importantly, is the idea that a lot of the things we pick up, malnutrition, falls, functional impairments, they have interventions. You know, there's physical therapy, occupational therapy to improve function, and really using these may improve oncology outcomes. And I'll talk a little bit in a couple of slides about some of the latest research coming out that shows using the geriatric assessment to inform interventions such as we just talked about can actually reduce the severe chemotherapy toxicities. So I did want to just show a little bit of the evidence highlighting some of those points. You know, one was, you know, can this predict survival? And this is a study that I was part of back at the University of North Carolina at Chapel Hill. And it clearly shows in a majority breast cancer cohort that patients that are robust versus pre-frail or frail have very significant differences in their overall survival. And I think this can be very helpful in predicting the benefits of these adjuvant treatments. Again, predicting chemotherapy toxicities is probably one of the biggest challenges we have as a medical oncologist. You know, that's why patients often come to us, and it's left to us to make these decisions about chemotherapy. And, you know, we're not that good at knowing who's going to tolerate and who won't. Arthi Huria, again, one of the seminal leaders, published this seminal work in JCO back in 2011, and it looked at what are the predictors of severe chemotherapy toxicities in older adults. Some of these things are what we'd expect, you know, low creatinine clearance, hemoglobin, but also some factors that are not typically part of your oncology assessment were significantly associated with severe toxicities. So we would all recognize that if you have poor kidney function, you would likely be at increased risk and require a dose reduction. But we had a similar odds ratio for severe chemotherapy toxicities in patients that were reporting falls. Additionally, hearing impairments, limitations walking a block, and an IEDL impairment with medication intake. So I think it shows you how, you know, really this is a helpful tool in predicting who's going to have severe toxicities and may not tolerate treatment. Here's how this stratified patients according to this, you know, CARG toxicity risk score. And here is how the typical performance status stratified out these severe impairments, severe toxicities. And as you can see, you know, whether you had a perfect Karnofsky performance status or a very low one, they all had about the same amount of severe toxicities. Now, again, I wanted to emphasize how this can be used as an intervention tool. And to me, there's two interventions that can be done. You know, one is a more general geriatrics intervention, which is really what I've been talking about the most, such as if someone's having falls, there's a falls evaluation, physical therapy and occupational therapy. If you're malnourished, you should see a nutritionist and get a nutrition intervention. You know, those are kind of standard things that, frankly, even if you're not in an oncology clinic, you should be doing. But then there are certain modifications that we can do as oncologists to help as well. Now, what is that? Well, you know, for me, if I'm seeing someone with newly diagnosed colorectal cancer, you know, do I want to give full dose FOLFOX, or do I want to use a dose reduced FOLFOX? You know, particularly around the oxaliplatin and the 5-FU bolus. Often in more frail or vulnerable patients, we'll omit the 5-FU bolus and do a 20% upfront oxaliplatin reduction, similar to what was done in the FOCUS-2 trial. Also, we have the opportunity of doing single agents such as capecitabine or 5-FU alone. So we can really, in those, modify our treatments. In those that are particularly high risk, frail, or vulnerable populations, I would argue they should not be getting these full doses, and consideration for single agent plus minus targeted agents would be very reasonable and looks like actually it could be more beneficial. Because what often happens if you use just standard doses, they have severe toxicities, hospitalizations, and stop treatment. Whereas if we use a dose reduced or single agents, they can stay on treatment and therefore, get more benefit. Here are some of the most recent, this is actually from ASCO 2021, so over a year old. We're still waiting for some of these to be published, 2 of which I actually know are going to be released very soon in Lancet and JAMA Oncology and have been accepted but not yet published, but are using this tool as an intervention. So they're taking these patients, they're providing this information to the oncology providers and doing these geriatrics interventions. And 2 of these studies have really shown that they were able to decrease severe toxicities by 10%. And these are large randomized studies, 1 cluster randomized, 1 is a single institution randomized, another one that was actually pre-surgery and showed that it reduced hospitalizations after operation and lower length of stay in the ICU. So the evolving information and data on how to use this as an intervention tool is growing greatly and will be in just the next few months as these publications actually come out. I did want to just show a slide about how this can be used by different domain impairments and things that you could use as interventions. These are more the geriatrics interventions. And now we do have oncology guidelines specifically for the older adult. Now we have these via the NCCN guidelines, ASCO guidelines. There's lots of guidelines that exist. But now, given the evidence, it is recommended that every older adult over 65 that's considering chemotherapy, that's where we have the most data, really should be getting these geriatric assessments as part of standard of care. Now, going back to that survey, are people performing this as part of standard standard oncology care? And the answer is unfortunately not. Given some of the recognized barriers, currently, this is an underutilized tool. This is the international survey, so I would say really across the board. And when we really look at what are the barriers to using it, it's still this lack of awareness and uncertainty of which tools, this lack of training, which is why I'm glad to be here, and I'm happy to take more follow-up emails on how to use this. But lack of training, lack of support staff and time. I think we're all very busy and we're trying to develop better models and more streamlined approaches to incorporating this. Now, when we did this assessment, we did this survey, we looked at those that were aware of ASCO guidelines and those that weren't. And I think this is important because it kind of shows you 2 patterns. There are many of us that are kind of more aware of this evidence. And these are people that I think recognize the importance, but just have difficulties with lack of time and support staff in doing it. And then there's another group that just is less familiar with this entirely. So they lack the training and knowledge and just don't know what tools to really use. I think the good news here is, it's not an issue of limited evidence. I think the evidence is continuing to grow and only getting better. But even today, we have significant evidence that these can be beneficial in the management of our older patients. So lastly, I just wanted to go through a quick case example of how this can be used in practice, and then I'll stop and take any questions. So of course, I'm a GI oncologist, so I thought I'd use a colorectal cancer example here, but Mr. Smith is a 75-year-old gentleman with coronary artery disease, hypertension, hyperlipidemia, and osteoarthritis that's on a couple of medications when recently found to be anemic on his annual visit with his primary caregiver. Underwent a colonoscopy and found to have a sigmoid mass, and for the rest of his CT staging did not have any evidence of metastatic disease. He does undergo a hemicolectomy and found to have stage 3C or T3N2 colon cancer. Now, what if this patient was 85 years old? Would that really change your approach here? So really the important thing here, which I've tried to highlight, is we really need to know, a little bit more information about what we want to do. So these patients undergo a geriatric assessment, and it's found that the 75-year-old actually has, impairments in his instrumental activities of daily living, falls and mild cognitive impairment, which really puts his life expectancy at the lower range, only about, 3 to 5 years, and a very high risk for chemotherapy side effects. Whereas in contrast, you can have an 85-year-old that is fit and doing well and not have any of these impairments or significant comorbid conditions that would have a similar, if not even longer, life expectancy, and would be really lower risk for chemotherapy toxicities. Now, I did want to show you, so if you're wanting to predict chemotherapy toxicities, you can actually go to what is called the MyCARG website, or it's the Cancer and Aging Research Group, which is CARG. Just type in CARG toxicity calculator, it'll come up. This is kind of what it looks like, and these are these two patients put in. This is showing you that the 70-year-old really would have a 92% risk of severe chemotherapy toxicities, whereas the 85-year-old would be 44% risk of severe toxicities. I know the 44% actually still sounds a little bit high, but in reality, older adults have about a 50% chance on average of severe toxicity. So he's under the average here. This is a tool which actually is not available online, but used to be back when I did a lot of my training, which is this Adjuvant Online tool. There are other things now, like Predict Plus and breast cancer out of the UK. But this kind of gives you this idea of this adjuvant chemotherapy benefit. And I think I only want to show this to show that in a patient like this one, that really, if you look at their 5-year mortality risk, the vast majority of patients will be, not surviving, but most of them will not be dying from their cancer. It's only this 7.4% out of 100 patients that will really die from colon cancer in this scenario. And when we're talking about adjuvant chemotherapy, that's only the slight segment that you can actually try to improve. And if we did, at this point, 6 months of 5FU therapy, you can only improve their overall survival at 5 years by 1%. And on the flip side, they have a 90+% chance of severe toxicity. So I would argue in this patient, I would not proceed with adjuvant chemotherapy. We've developed algorithms to kind of help, particularly in colorectal cancer, that incorporate, life expectancy, goals of care, whether they're fit or frail, and their toxicity risk. I think these things can be helpful. And in addition to that, we have guidelines now that can be very helpful. I know a lot of people want to use the NCCN guidelines, which are updated and reviewed annually. A lot of people use these for all their disease types, but importantly, they do exist for older adults. And you can see here, if there's any concern about how a patient, regardless of age, will tolerate therapy, it's recommended they undergo a geriatric assessment. And even in those that you aren't concerned, it's still worth doing a screening exam, even just a 5 or 6 item tool, to just ensure that they are not at risk for some of these things that we might miss. And there's some algorithms and some great resources here in the guidelines. So in conclusion, older patients require specific consideration during decision making for cancer treatment. I know I focus a lot on chemotherapy. That's a lot of what I do, but also, surgery, this is very pertinent, as well as radiation therapy. So I think, I've showed you, hopefully, a little bit more about what a geriatric assessment is and how it can actually aid in risk prediction, but also in guiding and personalizing cancer treatment, which can lead to these, cancer treatment modifications, as well as some other geriatric interventions. And really, when we're trying to put this all together, it's really a careful balancing act. So we want to think about the likelihood of benefit. What is the treatment? How much is this going to help either, improve their odds of cure, or how well is this going to control their cancer and for how long? On top of that, we really need to be thinking about the likelihood of harm. What is the potential for severe chemotherapy toxicities or any sort of adverse event? And then ultimately, we really need to inform this by a patient's preferences. Some patients really want aggressive chemotherapy, even if there is a higher likelihood of adverse events, whereas others would, don't want this aggressive treatment, and would really preferentially want to focus on quality of life rather than the quantity of life. So I just want to acknowledge, my institution, funders, everyone that I work with as far as mentors, co-investigators, and collaborators. And I will go ahead and stop there and take any questions. I did want to put my email up here, or for those of you who are on Twitter, feel free to reach out to me via either way. And I'd be happy to discuss things further and help out in any way I can. So I think you're on mute still.
Sorry about that.
Yeah, I do it all the time.
Thank you so much, Dr. William, for your outstanding talk. We have 5 minutes for questions from the audience. Let's see. Dr. Joel Moreno, considering that both scenarios are bad, what are you most afraid, over or under treatment in geriatric population?
Whew, that is a wonderful question. You know, I'm a little bit afraid of both. You know, sometimes I do this a lot, and I sometimes start to get worried, you know, am I over treating? Am I under treating? You know, what I think, I would say it's a little bit equal, but you know, I would guide that by patient preferences. So, you know, if a patient really, really wants to be aggressive, if I'm over treating a little bit, and at least if those are consistent with each other, you know, concordant, then I think we're doing our job. You know, what I don't want to do is, you know, aggressively treat someone that doesn't want that, that wants to focus on quality of life. So you know, I didn't talk about it a whole lot, but I really do think that this needs to be balanced with patient preferences, and that really kind of informs a lot of this and kind of pushes you one way or the other. And as long as, you know, as long as those are concordant and matched, I'm okay with it. You know, I have a lot of pancreatic cancer patients, and particularly if you're an 80 plus, you know, we often don't treat a lot of those patients. You know, the benefit is not real high and the risk are very high. But then again, if I see a new colorectal cancer patient, it's a little bit harder not to treat, at least with something, given that we have good treatments and we know the benefit is a lot higher with more tolerable treatments. So I think the scenario makes a little bit of a difference. But I guess in short, I'm worried a little bit about both, but I really would want to inform that by the patient's preferences. Great question.
Good. Another question from the audience. Do you think that the geriatric assessment should be done only by a geriatrician, or should it be done by a primary care physician, internal medicine, oncologist? What are your thoughts about that?
So I don't know that we have exact answers there yet. It depends on local resources. You know, if you're in an academic center and you have access to geriatricians, you know, that's great. That's wonderful, and perhaps the, you know, ideal circumstance. In reality, you know, these are the majority of patients that we're seeing. So I don't think all patients are going to benefit from that in particular. So I kind of reserve that for, you know, the highest risk patients that I'm most concerned about. I really think, and my goal in life is to try to develop and streamline these assessments to be done by the oncology team. You know, I don't want to make more work for the oncologists because they are already busy doing their thing. I think their job. I think we need to automate a lot of this as much as possible, meaning, you know, referrals to nutrition, referrals to physical therapy, those sorts of things, if local resources allow, I think should almost happen automatically. And then I think in a very simplified version, we need to provide this to the oncologist to help inform decision-making. That whole idea of, you know, do we need full dose or dose reduced? So I think giving this in very simple terms, the red light, green light, yellow light, and giving them a % risk of severe toxicities, and then let them use that to inform their overall management. So I think it's going to be a little bit of a mix, and it really depends on local resources in the setting, and how high risk these patients really, you know, are.
Okay, one last question from the audience. What adjustments did you do in geriatric population during COVID-19 pandemic?
Ooh, yeah, COVID's affected nearly everything. You know, it's definitely changed some of the approach for adjuvant treatment. You know, some of these benefits in adjuvant therapies are not, you know, really large. And the risk of COVID while on chemotherapy, you know, it just kind of moves the pendulum when you look at the risk-benefit analysis. I've had, you know, more than a couple of patients on active chemotherapy pass away from COVID, unfortunately, and, you know, can't help but think that, you know, the chemotherapy definitely made them, you know, at risk to be having, you know, worse side effects with that. You know, we definitely, from a model of care standpoint, you know, we're doing a lot of telehealth, televideo, you know, we're seeing patients as much as possible via phone and video chats as we can. infusions still are an infusion. So we got to get people, in the infusion area, and we try to help with that. I think, one of the biggest challenges we run into with older adults, particularly those with cognitive impairments, is we are limiting caregivers. So we almost always, and still is the case, that only allow the patient to go back by themselves. That can be a real challenge in the emergency room for many hours or an infusion. I wish we had better ways to adapt that for older adults, and we try to make some exceptions, but as you know, a pandemic is very challenging for those. So, it's impacted our care in several different ways. The telehealth maybe is a good thing, and hopefully we'll keep that, but other ways it's been very unfortunate. Great question.
Okay, one last question. Dr. Santa Maria wants to know, how do you handle when there is a patient who wants treatment and that is not of a benefit? How you handle that?
It's delicate. These are tough conversations. I feel like this is true for cancer, but also true for COVID currently. Do we give ivermectin and some of these treatments that we have, no real great scientific basis, or have no evidence? I try to have a discussion with them. Ultimately, if I don't think it's effective, I will not prescribe it. There are times where people ask about over-the-counter things. If I don't think the risk is great, and if it's going to make them feel better, and it's something that I don't think has been well researched, sometimes I'm not going to actively dissuade them. I'm not going to prescribe it, and I'm not going to give an infusion that I don't think makes sense or benefit. It's hard. Some patients come away from those conversations not real happy. I try to, explain the rationale of why we develop therapies, the hierarchy of information, phase 1 through 3 studies. But ultimately, I will not give therapy that I don't think is effective whatsoever.
Got it. Thank you so much once again, Dr. William, for your talk. We hope to invite you in person next year. Hope we are better with the pandemic. We're all vaccinated.
Absolutely. It would be my pleasure. Thank you for having me, and keep me in mind for next year, for sure.